Good afternoon, everyone, and thank you so much for joining us for day 3 of our third annual Inclusive Excellence Week here at the School of Dentistry. We are so excited about all of the programming that we've offered this week. Particularly excited about today's speaker, Mariah Williams, who is a VCU alum. She is an urban planner, a storyteller, a researcher dedicated to highlighting the experiences of Black people and spaces in cities. She received her BA in sociology from the University of Richmond and a master's of urban and regional planning from Virginia Commonwealth University. She is the founder of Finding Homeplace, a platform that highlights the work of Black women in community development, discusses the history and legacy of inequity in communities, and reflects on Black expression and resilience in urban landscapes. Her work on Black joy, Black women, and community has been featured in Next City, For Harriet, and the Third Wave Urbanism Podcast. So it is really my honor and our privilege here at the School of Dentistry to have Mariah Williams with us today. Spoiler alert, social determinants of health include housing. And so that is really the reason and the rationale for why we have her here with us today, so that we can know more about how housing policy impacts health outcomes and that we can be better providers and caretakers of our patients. So I give you Mariah Williams.
Thank you so much, Dr. Smith. And good afternoon, everyone. I am really excited to be participating in the third annual Inclusive Excellence Week. Again, I am Mariah Williams, and I am going to be leading us in what I hope is going to be a wonderful and substantive discussion and presentation about housing and how where we live impacts us, including access to health, as well as health outcomes. And so I know that you all have had the chance to hear my bio, but I did want to start by telling you a little bit more about myself and how I show up to this work. As Dr. Smith mentioned, I am an urban planner. I am a VCU alum. I received my master's of urban and regional planning from the Wilder School at VCU. And I am the founder of Finding Homeplace, which is really a platform that is dedicated to highlighting the stories and experiences and the work of Black women in community development, as well as examining the built environment from the intersection of race and place. And I also really like to use this work as an opportunity to tell stories about my community and other communities and how they are created and sustained, because I think they help to bring people together. And so I actually wanted to start by briefly telling you my personal story. I was born and raised in Harlem, New York, to a single mom, and we didn't have a whole lot in terms of, financial means. But one of the things that was always really, really important to my mother was just making sure my brother and I were connected to educational opportunities. A lot of times, those were not in my neighborhood of Harlem. And I remember growing up in the city and taking the bus or walking somewhere and seeing that as I, went farther downtown, how the neighborhood changed. The streets got cleaner. The people often got whiter. There were more trash cans. There were less liquor stores. There were more traditional financial institutions and less check cashing places. And so even before I could really conceptualize or even knew what urban planning was as a profession, I was making the connection that the community in which I lived, that was predominantly African American, it was a community that was severely disinvested in and that did not have the resources of the communities that I often traveled to for opportunity. So why do I share this story? I share this story because it wasn't until later that I realized that the disinvestment that I saw in my own community, that I'm sure many of you have seen as you kind of worked and lived in this city, that it was tied to something more intentional than I knew at the time, and that it was actually a result of historical disinvestment and a legacy of intentional policy decisions. And so that is a large part of what, we'll explore today, in addition to really understanding how the legacy of this inequity that we see in housing is really connected to health outcomes, and hopefully can provide some context to how you show up to your work as you are interacting with communities and as you are interacting with the patients that you all serve. So I don't claim to be a historian, but what I would like to do is ground us in history to really understand this inequality, because as we see it unfold in institutions today, it's really a part of a long history of racism and discrimination in 20th century housing policy. So I just want to name that. I won't spend a lot of time here because I am confident that most of you know about social determinants of health, and really, them being the non-health conditions in our environments where we work, where we live, where we learn, where we age, that affect a wide range of our health and our just overall functioning and quality of life. And as Dr. Smith mentioned, not surprisingly, the built environment and housing and neighborhoods are part of those determinants. But I also would like to introduce a framework for those of you who may not be familiar to this. It's something called the Pathways to Health and Housing. And this is something, kind of a framework from a report that was produced by the Robert Wood Johnson Foundation. And it really explores things like housing instability, quality and safety of housing affordability, which I think is something that has become, really significant over the past several years in this housing market, and neighborhoods, and how all of these things within the housing space impacts our health. And so I will spend some time at the end talking more about how the legacy of discrimination and racism in housing has a significant impact on all of these areas connected to the pathways. So as I transition into talking about the historical, history of housing policy, I want to remind you of this. And quite frankly, I don't think it'll be hard to see this as a part of this presentation, that the systemic inequity we see in the built environment today, which disproportionately impacts people of color, is not an accident. It is intentional, and it is by design. And I'll also add that the history of racism and kind of how we see it unfold in some of our kind of our policy spaces goes farther back than this, right? But we have limited time together, so I'm going to highlight some that I think are really significant in terms of understanding how our neighborhoods and communities have really been entrenched with these types of policies. And so I want to start with the Great Black Migration, which is not housing per se, but this is a pretty significant period that really shapes the urban fabric in northern cities between the periods of 1910 and 1970. And for those of you who are not familiar with what the Great Black Migration is, it is where you had large swaths, millions of Black people fleeing the terror and the violence and the cruelty of Jim Crow South and settling in northern cities. So our Chicagos and our New Yorks and our Detroits. And this becomes important because while Black folks left the South for the with hopes that there would be, more opportunities economically and otherwise, because there wasn't necessarily overt racism. What we find is that in response to this movement of Black bodies and other economic conditions that I'll talk a little bit about, the government actually responds by passing a series of legislation to ensure that African Americans are relegated to certain communities and really aren't able to take advantage of those things that we know were associated with the American dream, most significantly being housing. And so a few things that I'll highlight to show examples of this, some of which you may be familiar with, are redlining, the practice of redlining, the development of public housing, and how segregation and disinvestment was really kind of entrenched in the development of public housing in this country, and especially in the city of Richmond, and then the Federal Highway Act. Again, not a comprehensive history, but just a few examples that we can look at. So 1933, we're in the midst of the Great Depression. Keep in mind, I also mentioned the Great Black Migration, right? So you have this kind of economic suppression in addition to this movement of African Americans. As a way to kind of refuel the economy, to get the country back on its feet after the Depression, housing is really seen as the engine to do that. The National Housing Act of 1933 set up what is known today as the Federal Housing Administration, the FHA. And the FHA was really designed to ensure mortgage loans made by banks, right? To make sure that those loans had some type of backing. This is language that was essentially written into the lending practices of the Federal Housing Administration. And it says, if a neighborhood is to retain stability, it is necessary that properties shall continue to be occupied by the same social and racial classes, right? So here, I think, is an early example, specifically in the community development and housing space, where we have language that is, codifying segregation and racism as it relates to lending practices. As a part of the FHA being set up, there was the Homeowners Loan Association was also set up as a part of this. Again, we are coming on the heels of a depression. There are high rates of foreclosure. And so the HOLC was really set up to fully amortize mortgages to make sure folks were able to pay them back. They are credited with extending the repayment periods to 25 to 30 years, much of what we see today, and really saving homeowners from going into foreclosure. Most importantly, they are credited with institutionalizing something called residential security maps, and the practice that we know as redlining through the creation of these maps. And what they would essentially do with these maps is they would travel around the country and go to neighborhoods and essentially grade those neighborhoods based on their worthiness to be, backed by a government loan. And so they would grade these neighborhoods, A and B being, pretty good neighborhoods, ones that, the folks that live there could take advantage of, mortgage loans. And then once you got to C and D, this is where you started to see language to discriminate against the folks who lived in those communities. Most often were folks of color, most often African Americans. So if a neighborhood, by the time a neighborhood got to D, redlining, that meant that a neighborhood had fully declined and was categorized by a detrimental influence in a pronounced degree, which meant that individuals who owned homes in those areas were not able to take advantage of mortgage loans that were backed by a government institution, refinancing products, etc. And why this is so important, as we know, is because owning a home is, the number one way that individuals have built wealth in this country. And so when you talk about communities that were effectively shut out of this certainly has significant implications for not only wealth building, but for accessing other opportunities as well. And so I'm sure that many of you are pretty familiar with this map. This is a residential security map from the city of Richmond. This is one of many maps that were created for cities across the nation by the HOLC. And this map really becomes the blueprint for inequity in this country. We know that individuals that live in previously redlined neighborhoods have shorter lifespans, have higher rates of chronic diseases, such as asthma and diabetes and hypertension, obesity, kidney disease. The list can go on. And I will also show, when you do a side-by-side between this and kind of where future planning interventions happen, where our public housing is located in the city, you will see that the communities that were redlined have continuously been impacted by planning decisions as well. And so we also know that the communities that experience this redlining were disproportionately African-American communities. So this shows the concentration of African-Americans versus white households in those communities. The further west we go, those neighborhoods were less likely to be redlined. And we can kind of see that in the resources that are in those communities today versus the further east. And when we go south, those are the communities predominantly African-American that have experienced the most disinvestment. Another kind of significant point when we think of planning history that has really kind of, worked to, I think, the planning history that has been kind of significant in showing the impacts of inequality is the Wagnall-Steagall Act of 1937. Essentially, this established the country's public housing authority, right? And what we saw with the passing of this policy is that it was almost always built in undesirable neighborhoods and disinvested neighborhoods that often had income restrictions. So that effectively guaranteed that there would be a concentration of poverty. And if this wasn't enough, right, you fast forward and in 1956, under the Federal Highway Act, which authorized the building of the interstate highway system in this country, Black neighborhoods were almost always significantly impacted by this. Even though community members protested, the highway systems in this country were almost always built through Black communities. For those of you who who live in the city or maybe from the city, Jackson Ward is the most prominent example of this happening in the city of Richmond. So this is an image of a fully flourishing neighborhood in 1956, St. Paul and Duval Street in Jackson Ward. And about a year later, here's what we have. So you can see the destruction of homes and neighborhoods in this community. And then a few months later, the area is completely razed to prepare for the development of the highway. And so when we say redlining becomes the blueprint for equality and the inequity we see today, here is really what we mean. And I do want to add that, I spent, the last several minutes going over how these policies were passed on the federal level. We can spend even more time talking about how there were state policies that worked in parallel to these federal policies to also ensure residential segregation and disinvestment in communities of color throughout the Commonwealth of Virginia. And so Even again, when we look at the legacy of redlining in Richmond, if we do a side by side, so on one side, the residential security map, the redlining map, and on the other side, in kind of the shades of red, this is where public housing between the years of 1930s and 1960s in the city of Richmond, we can see that they were almost exclusively built in the east end and then in the south side of Richmond, in neighborhoods that had been formerly redlined. So out of the 6 public housing developments, they are concentrated in 2 areas of the city. When we do a side-by-side for kind of the neighborhoods that experience the highest rates of poverty, and I apologize for that being a little tiny, I will send this presentation to Dr. Smith after so everyone can see. We can also see that the neighborhoods that experience the highest rates of poverty, the neighborhoods that have children living in the highest rates of poverty, also tend to be in the communities and the neighborhoods that were previously redlined as well. Median household income, we also see that pattern, right? Where our higher median household income tend to be as we drive west in our city versus the households with the lowest median household incomes, again, are in our areas that were previously redlined, are in our areas that have historically had public housing. And then racial disparities in evictions, which I'll talk more about when toward the end, when we talk about the impact of housing instability and on health. So in 2016, I think really shed a light on the city of Richmond's eviction problem. Matthew Desmond from the Princeton Eviction Lab and then the book Evicted, really, I think, forced the city to reckon with the problem of eviction, right? And so what this map shows essentially is that in the communities that have the highest rates of eviction, they also tend to be they also tend to have higher percentages of renter householders who are African American. So I think this really highlights the racial disparities of evictions. We also know that evictions tend to impact female heads of households with children as well. And then finally, food access, right? I think, many of us have probably been a part of conversations as it pertains to food deserts in the city of Richmond and just the lack of food access for certain communities. I happen to live in the East End, and it wasn't until a couple of years ago where there was a grocery store that was, put into the community that was at least within, walking distance. And obviously we can speak to what a lack of access to healthy foods, healthy fruits and vegetable can do, to a community. And again, we start to see the pattern that the neighborhoods that have experienced redlining are also the ones that are food deserts, or as someone I'm now trying to say food apartheids, because again, the intentionality of a system that was set up to ensure that this was the case. And so I think, there are significant health implications and outcomes for individuals that live in communities that have experienced decades upon decades upon decades of codified, disinvestment, going back to the early of 20th century. But again, I think if we had the time, just discussing, what that has looked like even before then. And so I do want to kind of reorient you all to going back to the pathways of health and housing, which again is kind of a framework to really think about how those two things are connected. And so when we think about housing instability being one of them, we know that individuals that experience homelessness and housing instabilities are 3 to 6 times more likely to become ill and have hospitalization rates that are 4 times that of the general population. And so that is something that, you know, we all pay for, right? That is just not sustainable when we think about the fact that people who are experiencing housing instability tend to overutilize certain systems of care. The lack of housing, stable housing, can also decrease the effectiveness of healthcare by making things such as like the proper storage of medications difficult. And I think in general, just the long-term effectiveness, of healthcare as well. And then residential instability is also associated with health problems amongst young people, including, you know, increased risk of teen pregnancy, being prone to like early drug use, as well as anxiety and depression as well. And more specifically, when we think about the impacts that housing instability has on children, it is pretty significant. So children are significantly impacted by housing instability. Studies show that this is the case even in utero. And so when we talk about why maternal health is so important in general, but especially why maternal health is important for those who experience, mothers that are experiencing housing instability, this is one of the reasons, because that is literally passed on to that child in utero, but also will impact, once they are born, how they are kind of experiencing kind of their day-to-day if their parents are experiencing housing instability or homelessness. Infants born into homelessness tend to have low birth weights and are 9 times more likely to die within the first 12 months of life. And then homeless children and children experiencing housing instability are sick 4 times more often than children who are not homeless and have an increase of things such as asthma and iron deficiency, lead poisoning, respiratory infections, ear infections, gastrointestinal problems, and then a host of emotional and behavioral problems, anxiety, depression, withdrawal, all the things I think associated with not knowing where you are going to lay your head at night, not knowing the next time you may get evicted, not knowing, you know, when your parent may lose their job, and so that might kind of shift you, not knowing if you're going to have to change school because you have to move again. As it relates to evictions, which is you know, one of the causes of housing instability. Individuals who experience an eviction are more likely to report poor general and mental health outcomes compared to those not evicted. And this is seen, and this is from a study that I read and taught in one of my classes. This is seen in both kind of the short term and long term. So it doesn't really matter how long someone after eviction they're experiencing these issues. Counties and cities, in general, places with high rates of eviction are more likely to have higher substance use related mortality rates. And then mothers who have been evicted are more likely to report poor health outcomes for themselves and their children. And this is seen again, you know, very short time, even after they've been evicted, right? So those impacts on their health are quite immediate if they've experienced an eviction. Another pathway to health and housing that I mentioned at the beginning is housing safety and quality. And this pathway really focuses on the environmental factors within a home that are correlated with one's health. And this can include things such as air quality, home safety features, you know, the presence of mold and asbestos and lead. And it's also important to note that when we talk about safety and quality, it's impacted by the upkeep of the individual, sure, you know, such as the landlord or the owner of a home or a person that rents the unit. But I think it's also important to note that there is also a history in African American communities and communities of color of widespread neglect of residential conditions, right? And we've seen this in the historical historical neglect of our public housing, just, due to things such as funding, but also neighborhoods where, there are slumlords know where they can operate and they know where tenants aren't necessarily going to fight back. So they are not inclined to keep a property up to code. So that means that a family might experience these conditions even more because of that. Excuse me. The other pathway is the housing affordability pathway, and this examines the ways that a lack of affordability to accessing housing, in addition to maintaining housing, can impact one's health. And I think, simply put, the more a household spends on housing means the less it can go toward healthcare, the less it goes toward an emergency savings if there is, a health crisis, the less it can go toward things that we know are associated with the high cost of healthcare in this country, co-payments and deductibles as well, right? And I think the pandemic certainly shed a light on, just the really thin margins that families, were existing in when it came to, one paycheck meant that they could either be homeless or they just, were not able to, pay for quality health care. There is something in housing called cost burden, and that is essentially the amount of your monthly gross income that is going toward your rents. If 30% of that is going of your gross income, your monthly gross income is going toward rent, that is something we call that cost burden. Severely cost burden means that like 50% of your monthly gross income is going toward rent. And so again, the more that you are paying toward rent means the less that you have for these other things, including remaining stably housed, but also being able to access quality healthcare, be it in your community or somewhere else. And it means the less you have to put toward other things, such as, purchasing food. And I think in this current climate thing with inflation, things are extremely, extremely expensive, right? And so if I'm focusing on just staying housed, other things for me kind of fall by the wayside. And then the final pathway is the neighborhood pathway. And this is really about the ways that our physical environment, our physical surroundings impact our health, both on a micro scale, but also a macro scale. So this can include our proximity to green spaces and to parks. Again, our proximity to access nutritional food, so grocery stores, but also things like access to transportation. And I think general connectivity to other amenities. So one of the things that we have seen as a legacy of the systemic racism and discrimination built in our built environment is that communities that are impoverished economically tend to also be socially and economically isolated from many of the amenities that some of us are, able to take advantage of, right? Like I'm able to, walk to the grocery store or walk to the park and sit out and have green space, right? And so thinking about what that does, not only for our physical health and being able to kind of get out and be active, but what that has done, especially on the heels of a pandemic, for our mental and our spiritual and our emotional health as well. And then I don't have it in this presentation, but there was a research study done, I think, by the Science Museum a few years ago in the city of Richmond that shows kind of a map of the hottest neighborhoods in the city, right? And why they tend to be the hottest is because the materials that are often used in poor communities, they attract heat. So you're talking about asphalt and you're talking about concrete, but these also tends to be the communities where you see less trees and less green spaces, right? And so in the summer months, when it gets hotter, you literally have communities that are feeling all of that heat and therefore experiencing kind of the heat-related illnesses associated with that. The neighborhood pathway is also about thinking about our physical surroundings and the impact on one's health from a macro scale as well. So these kind of measures of segregation, but also thinking about like proximity to capital. So we talk about food deserts, but there are also kind of financial and economic deserts. So communities that where individuals do not and have not had traditional financial institutions. And why that's really important is because, like, if I am trying to figure out how to save better, so I can move, or if I'm trying to figure out how to buy a home, we most often in the past would do that by engaging with our neighborhood financial institution, right? But if I live in a community that does not have that, then I am forced to over-rely on, things like payday lenders, right? Places with excessively high interest rates, just because those are the only things that exist in my community. But this also includes, what is my access to quality medical facilities, and how am I able to kind of show up and interact with those places if they are, in fact, in my community as well. So I hope that you have walked away not only with an understanding of how housing policies impact our health outcomes, but how these inequalities are so deeply rooted. So I think the way I often, try to connect this, especially for practitioners who are showing up to work with communities and with individuals, is recognizing that when you are working with people, it's important not to be blind to the structural conditions that individuals have had to endure, that communities have had to endure. Because what I've found in doing DEI work and justice work and access work is that it sometimes becomes really easy to reduce these issues to, I think, just kind of like interactions and individuals' choice to not go to the doctor, to live in a place with mold, to live in a place that's infested with lead, to go to a certain school, right? But when we don't think about the ways that policies have really embedded these inequities structurally, then I think we kind of miss the larger opportunity to engage with people and really understand that the issues that they face on the day-to-day are much larger than what we can see and what we can imagine. And again, that they are intentional and that they are by design. And so with that, I think, we have some time for a conversation and discussion, and let's connect, right? Like, we have a limited amount of time together, but I'd love to continue to, think about how some of these things can help you all in your work as you are, really trying to remove barriers for the folks that you work with. So here's my information. And I think with that, I'll stop sharing, and maybe there are some questions that have come through.
Yeah, thank you so much, Mariah. That was fantastic. And for those who are live in attendance with us, if you have questions and you want to put that either in the chat or the Q&A, we'll certainly take that at this time. I think one of the most profound things, a lot of it was profound, right? But when you showed that initial map of the city of Richmond, with the redlining and the neighborhoods, and then subsequent maps that pointed out public housing areas or pointed out eviction percentages, I was thinking about the physical location of the dental school, and where it appears on that map and the surrounding communities. And we actually are, I believe, the second oldest dental school in the United States. The oldest is Maryland. I know that. And so we're the second oldest. So just the historic arc of location, right? And the patients that we still serve, and we're the only dental school in Virginia. So we're the largest, what we call safety net dental facility. And so it is not lost on us, this responsibility we have as this very public facing, community-oriented institution, which is even unique on the VCU campus, right? Because people don't go to the medical school for, their medical care, they go to the hospital or they go to a clinic, but people do come to the dental school. People don't go to the nursing school, to see a nurse practitioner, right? But they come to the dental school to receive dental care. So it's just really fascinating to think about our location and where we are as it relates to that. Some of the other things that maybe you could unpack a little bit more.
Sure.
You mentioned the term food apartheid.
Yeah.
And so could you unpack that a little bit for us and help us give us a little bit of insight of why that's a term that maybe you prefer to say food desert?
Yeah, thank you for that question. I remember some of you may be familiar with Duran Chavis, who does a lot of work around food justice and food access in the city of Richmond and just beyond. And I remember this was years ago. He came to one of my classes when I adjuncted at VCU, and he said, I use food desert, right? Deserts are something that are kind of a natural occurrence. They exist. Apartheid, when we think about, apartheid in South Africa, it's a system that was intentionally set up to exist the way that it existed and to have the impact that it has. And so when I think about the reason why I have kind of moved to not saying a food desert versus, a food apartheid is because I think it goes back to that intentionality piece, right? That where things are built in our communities is by design, right? There is a reason we have not, or we do not see certain things. And I think that's changing in the city, but I think the apartheid speaks to the intentionality of policy choices and that people made those decisions to do that. It's not like a desert that was just created and it's this beautiful phenomenon. No, it was a system and a history of choices that were made.
Yeah, no, that's so helpful. Because my area of scholarly interest is ethics and professionalism, I actually gave a presentation last week at a national meeting around social determinants of health and our ethical responsibilities, right? As those who espouse to uphold this social contract with the public and the society that we engage. And it was interesting. There were about maybe, 75 folks, from across the country in this room. And a very well-known dental educator came up to me after and said, "Oh, this presentation was fantastic. But I really think you should think about talking about social determinants of behavior."
Ooh.
And it was fascinating because I thought, wow, you missed the whole point of the presentation that was this is not specific to individualized behaviors or individualized choices. And I think probably for all healthcare providers, but especially dentists, because we really are doing behavior education, right? In the operatory, in the chair, one-on-one, make sure you floss.
Yeah, make sure you brush your teeth.
I think it's really difficult to separate out and think about this from a systems lens. And I think you really did a great job of helping us see that, particularly connected to housing, right? Yeah. And that we could connect to fluoridated water and what zip codes or towns or cities have allowed fluoride in their water and the prevention connection. So it's really rich. Yeah.
Yeah. And I think, and I didn't show this, but when we think about how racism operates, right, there are those micro levels of race, right? That's the interpersonal, the interaction, the interactional aspects of racism. But to your point, the structural and the institutional tells us this institution exists, but it's where I live is interacting with where I get my health access and where I go to school and all of these other things. And I think to your point, if we just reduce it to our interactions, we are missing just a whole bunch about how someone even shows up to the dentist, right? I think about where you are luckily positioned in a place that's close to transportation, public transportation. But if I'm coming from somewhere else, even just getting to you could be a barrier.
Definitely.
Right? So if I'm, working with someone, then it is a responsibility, a social responsibility, that social contract to take all of that into account.
Yeah. And I think it shows up even in, when you talk about policy creation, right? So very often in many dental offices, you can have sort of this three strikes you're out type of mentality, where, you know, if you no show for 3 appointments, or you're late for 3 appointments, or things like that. And I mean, certainly you have to come up with something, right? So that the system is not abused, and so that opportunities for care, you have people waiting, right? You have other people who want to use the care. But I do think it also gives an opportunity to have some creative latitude or some creative ingenuity to say, okay, literally, if the patients we're likely seeing are working poor hourly wage earners, and or folks that are retired on a fixed income or something like that, and their transportation is largely out of their control.
Yes.
Right. If they're dependent on a public transportation system that might not be reliable, if they're depending on a ride from their neighbor that might not be reliable, it is difficult to where does accountability come into play with someone who really is trying to just get to their appointment, but then feels dismissed because they were 15 minutes late. And I totally understand. We have to draw a line. We have to create policies. But I think we also have to have that empathetic side to us that figures out how can we maximize the needs of those folks who are coming to us with all these social determinants and things that are really can be barriers to them pursuing and wanting to be as healthy as they want to be.
Yes. And I think, I don't practice as a dentist, so I don't know how feasible, but I think one thing you said is like, them or folks who have experienced, you know, this, you know, historic inequity, coming to us. And I sometimes wonder in institutions that do have, you know, resources, what it looks like to go to them, right? To reduce that barrier to access. Because I think to your point, if the only time I can get to a dentist is between 9 and 5, well, guess what? I work between 9 and 5. And can I bring my child because I don't have access to childcare and I don't have a private vehicle. So I do have to take public transit. And is it in a place that I trust because I think it's real we have to acknowledge the distrust that many folks have of medical institutions in this city alone. I mean, the things that have been coming out, right? So I think it's also shifting this expectation that the folks that have lost the most to these policies are still expected to show up to us in wholeness and be able to operate, when I think in a lot of ways it should be the opposite.
No, that's really beautiful and so profound, and I think presents some challenges to us, not that we can't overcome, but almost to challenge us to be creative, to say, okay, let's think about this differently. Let's think about some creative appointment times. And I think some dentists are doing that, where maybe, you know, one day a week they open at 10, but they stay open till 7 and different things like that. So I think there are some alternatives. But I think just even articulating the concept for many people is totally out of the box, right? And so to get them thinking about ways that we can actually meet the needs of folks that are coming to us. So yeah, that's great. We're really at time, but I've so enjoyed the presentation
Thank you
and
so
the
much
conversation.
for having me.
Thank you so much for being with us today. Thank you so much for those of you who signed on live today. It is recorded, so it'll be available to our community. And tomorrow we actually have a dentist and physician. She is both a dentist and physician at Harvard, who's going to be talking about the integration of medical and dental services as a way to advance health equity. And so instead of folks having to go so many different places, what would it look like to have care kind of in one location? So I'm excited about that and how that piggybacks a little bit on what you showed with us today about the importance of place and location and geography. So thank you so much for joining us.
Thank you so much.
Yes, have a great one.
Everyone.
Have a great one, everyone. Thank you.